I have been attending online because of because it was available on YouTube and enjoying the sessions and the very interesting discussions that have been going on. And it feels great to be here back after almost 9 weeks of not taking a single class and not seeing the faces of my residents and my colleagues. So I'll be talking about UTI, basically urinary tract, lower urinary tract infections. वो दे दीजिए मुझे प्रेजेंटर हाँ. So this is basically the talk is based on these resources. I could not find any recent guidelines from the ACOG, but RCOG had a few recommendations, but again I did not have access to that because I was not coming to the college. So, and any guideline which is more than 10 years, I think it's, in any case, it's redundant. So, we all know, do you all believe that males and females are differently wired? We all believe. So there's a big debate, actually a lot of research, whether it is our brains are differently wired or because we are differently primed right from childhood. But anatomically we are different, that is something very, very evident and very clear, no debate about that. More than 50% of women will have one UTI during their lifetime, and 3 to 5% will have multiple recurrences because of these differences. Prevalence of asymptomatic bacteria is also higher in females, and it increases as they become older, more than 65 years of age. And UTIs are 14 times more frequent in women than in men. We all know the risk factors, that is the anatomical differences and the physiological differences that we undergo. So short urethra, intercourse, use of spermicides, diaphragms, history of previous UTIs in childhood, and underlying conditions like diabetes, they predispose to lower urinary tract infection. Apart from that, vaginal atrophy, pelvic floor relaxation, and hospitalization and systemic illnesses as we grow older. Routine pelvic examinations, surprisingly, I found are also associated with a high incidence of UTI in the next 7 weeks. Women with pre-existing UTI, structural anomalies, or I already told that, or obstruction, they also carry a higher risk of UTI. And of course, pregnancy and purpurium. So these are two conditions where we are more predisposed because of further anatomical changes that our body and physiological changes like immunosuppression that our body undergoes. Most, apart from that, complicated UTIs are related to hospital, procedures. And sadly, healthcare workers are many a times responsible because they do not follow proper standard infection prevention practices. And please remember, the most important risk factor for bacteriuria is presence of a catheter. We'll come back to that again. So the pathogenesis, of course, it's an interplay between host resistance and the bacterial virulence, certain factors in the bacteria themselves. So they are ascending infections, continuous unidirectional flow of urine prevents, and whenever there is an obstruction or that is inhibited, again the incidence will increase. So there will be a back pressure and collection, you all know, like in pregnancy, we are more predisposed to UTIs. Then IgA that is present in the mucosa helps in preventing lactobacilli. In premenopausal, most of the time it helps. And then urine itself has antibacterial features that suppresses UTI, the pH, the urea concentration, osmolarity, and certain organic acids, they also help in preventing UTIs. Then uropathogenic bacteria, they have special features which help them adhere, grow, and break the resistance of the host or its defenses and facilitate colonization. So E. coli, we all know, if you go back to your micro classes, adhesions like pili and outer membrane proteins enable attachment, whereas Proteus mirabilis, it just swarms and it has certain specific genes which makes it particularly, help it swarm solid areas like catheters. So that is the commonest bacteria that will be isolated. E. coli, of course, is 75 to 95% time it is isolated. Then Klebsiella, Proteus, Staphylococcus, Saprophyticus are there. But the resistance patterns depends upon the location from where we are getting the data. And I tried to, go through the Southeast Asian study, the edition of Novak's. We were looking at the references. Surprisingly, there was just one reference from our area. So the Southeast Asian edition dealing with UTI of Novak's also does not talk about what is happening in our part of the world. But yes, I found that among locales which have a very high multi-drug resistant UTIs, one of them is India. Okay. E cells sometimes may be formed apart from the bacteria that are there, and they are normally not found in urine specimen, and they may signify either true infection or just contamination because there is a vaginal infection. This is a whole subject, especially for us Indians. Tuberculosis may also may be the cause for these symptoms in many women. Okay. Then clinical manifestations, we all know the terminology that is used. You have simple cystitis, symptomatic infection limited to the lower urinary tract. And when it becomes highly symptomatic with fever, malaise, and it reaches the upper urinary tract, it is pyelonephritis. Then asymptomatic bacteria is considerable bacteria in a woman with no symptoms. Then uncomplicated UTI is again acute disease in non-pregnant outpatient women without any anatomical abnormality or without any risk factors like HIV or diabetes. Then complicated are urinary infection occurring in a patient of structural or functional abnormality of the genitourinary tract. It causes dysuria, may also cause frequency, urgency, nocturia, and suprapubic discomfort, occasionally mild incontinence and hematuria. Gross hematuria is rare. Commonly, when it is upper urinary tract infection, commonly presents with fever, chills, malaise, flank pains, costovertebral angle tenderness, and nausea and vomiting. These patients may not have signs of acute cystitis. Because of the referred pain pathways that we have been going around for the past 3 days, even simple lower UTI may be accompanied by flank pain and costovertebral angle tenderness. So, however, the rule is that assume that the presence of these symptoms represents upper UTI until proven otherwise, because urosepsis is a dangerous thing. We have seen patients dying within 6 hours going into ARDS and becoming a full-fledged case of urosepsis. A history of vaginal discharge suggests that vaginitis, cervicitis, or PID is responsible for the symptoms of dysuria, and therefore pelvic examination is indicated. Prior STD and multiple sexual partners currently is also important when you are asking for the history. Then the patient appears uncomfortable but is not toxic when it is lower urinary tract infection most of the time. Most adult women with simple lower UTI have suprapubic tenderness. Pelvic examination should be performed to exclude vaginitis, cervicitis, or pelvic tenderness, which suggests PID. Acute urethritis versus cystitis. Urethritis, it is gonorrhea and chlamydia most of the time. They may overlap that of cystitis, including acute dysuria and urinary hesitancy. Fever may be a component of urethritis-related syndromes in certain conditions like Rieter's syndrome, but rarely is observed in acute cystitis. Urethral discharge is much more suggestive of urethritis, whereas bladder-related symptoms such as urgency, polyuria, and incomplete voids are more consistent with cystitis as they relate to the inflamed bladder mucosa. So there's a whole list of differential diagnoses. Important is to differentiate between urethritis because the causative organisms are different, so you need to do that. Then apart from that, sometimes there's a bladder pain syndrome when she's especially coming with the recurrent symptoms. Then vaginitis also can be associated with dysuria. Predominant features, you all know the predominant features, the different types of discharges that may be there, and then of course PID. Then occult pyelonephritis has to be ruled out, especially in older age women, because in geriatric age group, they are unable to mount a fever or a WBC response. So you have to be very careful while you're taking the history. Only there'll be some confusion or delirium or those kind of symptoms may be there. and they will just report with, just a fall or something like that. Then postmenopausal may also have experienced senile urethritis. So in addition to burning frequency and urgency, they will also complain of vaginal and vulvar itching and discharge. Physical examination reveals a dry, pale vaginal epithelium and erosion of the urethral mucosa. You have seen it so many times in the OROPDs, which will respond to estrogen. So presumptive diagnosis of UTI is made by history, clinical examination and analysis of urine, and presence of WBC in urine and nitrite positive testing, test positive indicates UTI, lower urinary tract infection, and urine culture is not routinely indicated. Urine dissect testing for leukocyte esterase or nitrite is a rapid and inexpensive method with a sensitivity of 75% and specificity of 82%. It's a good screening test, but women with negative test results and symptoms should still have a urine culture or urine analysis or both performed, because false negative results are common, because this is related to the gram negative bacteria only. So if it is being colonized with a gram positive, it will be false, false negative. A positive test suggests a UTI, but a negative test does not rule out. That is the dictum. A urine analysis with positive tests for nitrites, leukocyte esterase, and bacteria is highly suggestive of UTI. So, routine microscopic examination is a standard will detect. Okay. Somebody just give me my mobile phone. I'll continue from there. If you don't have the. Acha. So what bacterial count should be taken as positive for UTI, suggestive of UTI? From the postgraduates, you're doing it all the time. 10 to the power 5. Okay? But if it is, the urine specimen has been directly taken from a suprapubic tap, then lower maybe. Or if she's symptomatic, then also a lower count may be taken as positive. Okay? Then the next is urine culture. That is the gold standard for diagnosis. It is not necessary in all cases, and most of the guidelines recommend that for the single episode, she's coming directly to you. Do not wait for the culture, and no need to send the culture sensitivity report. We have to use our resources, in a very intelligent manner, because we are working in a poor resource country. Although not necessary in all cases, the culture, urine culture is performed. When will you perform a urine culture? किन केसेस में रिकमेंडेड होगा? सिंगल एपिसोड में नहीं है, फिर किस में होगा? रिकरेंट है या रिलैप्स सस्पेक्ट कर रहे हैं आप, ठीक है, देन इट इज रिकमेंडेड. ठीक. A bacteria is found and a UTI is suspected, urine culture with, sorry, if bacteria is found and a UTI is suspected, urine culture may be sent. If catheterized patients, or we have already discussed that, otherwise generally okay. The American College of Obs and Gynae, but that is again an old guideline, 2010, recommends that a urine culture is not required for the initial treatment of women with a symptomatic lower urinary tract infection, with pyuria or bacteriuria or both. So you just start treatment, empirical treatment, no need to send or wait. In a UK study, and I have seen many residents making that mistake, even in pregnant ladies. Okay? In a UK study, dipstick diagnosis proved more cost effective than positive midstream urine culture for targeting antibiotic therapy, and this is quoted by the 2010 ACOG guideline. So other findings that you may have sometimes in cases of UTI is that the microscopic hematuria may be there in almost about 50% cases of cystitis, and a low-grade proteinuria may also be detected. So we see so many times, patients admitted, they have proteinuria 1+ with urinary tract infection. Then does anybody know what is sterile pyuria? So I'm sure this is Nishat. I can recognize the voice. So she gets a chocolate. Can you help me? uh, where is that packet? Okay, please give her one chocolate. So the presence of pus cells, 5 to 8, yeah, clap for her, per high power field of microscopy in the absence of positive urine culture is known as sterile pyuria, which may be due to tuberculosis, renal or bladder calculi, mesh or sutures in the bladder, glomerulonephritis, interstitial cystitis, chlamydia or urea, plasma urethritis, or urinalysis which is done, culture that is sent after you have already started the antibiotics. So culture will be negative, but the pus cells may be there. Okay? So there are also some non-infectious causes of pyuria. When the woman is having persistent pyuria, that is not an indication to give her more courses of antibiotics. So these may be uric acid and hypercalcemic nephropathy, interstitial cystitis, sarcoidosis, polycystic kidney disease, genitourinary malignancy, renal transplant rejection, and any periurethral infections. So how do we send urine for examination? The most important part, we have discussed the investigations and we have discussed that no need for a culture. So do not waste time, money and energy in a culture. Yes. कैसे भेजते हैं सबको पता है हर वक्त मरीजों को बताते हो यहाँ पे बताओ तो चॉकलेट मिल जाएगी ओके so you have to tell her that do not touch the container or the inside of the cover of the container. What else? She has to retract her labia and not use antiseptics, clean the area, and midstream should be taken. Midstream sample should be taken. If she is menstruating, what will happen? And for the postpartum women, I have seen so many times, urine routine microscopic being sent, and there's full of pus cells. From where are all those pus cells coming? And the hematuria will be there because she's menstruating. So you have to tell her all those things. Ensure that she's not menstruating. She has to clean that area. Some people advise that ask her to use a tampon for that period when she has to send. And how do you send the urine for microscopic and routine? What kind of a vial? Sister, एक antibiotic की vial खोल के दे दीजिएगा. It will not work. Please. It has to be a clean vial, just like for a culture you are sending. Please remember that. Otherwise, your tests will be your tests will be the results will be false, and then they will trigger more investigations. Okay. So can we start? Okay. Yeah, very important point that Dr. Rishat has added, that you have to send it within 1 hour ideally, or store it at 4. Actually, urine itself is a very good culture media. Okay. एक मैजिमीन तुम भी उठा लो भाई. So just 1 minute. ये किसी ने आगे ही बढ़ा दिया था. अरे वाह. अच्छा. So we are here. So in the antenatal form itself, just on the reverse side of our antenatal form, we have put urine की जांच कैसे करानी है, सुबह नहार मुंह का पेशाब देना है, पहले बदन को धो लें, फिर सिर्फ पानी से बीच का पेशाब बोतल में जमा करें, बोतल का ढक्कन, all those details. So you have to Take the trouble or just ask her to take this pic. It is there in the OPD. Okay. Now a few questions again for more chocolates. Okay, why? More chances because you're concentrated. You don't wake up usually. Yeah. Yes. So visual, can it help you in diagnosing? मरीज आके कहते हैं बहुत बदबू आ रही है, गाढ़ा गाढ़ा से यूरिन आ रहा है, ऐसा लग रहा है जैसे उसमें कुछ मिला हुआ है. So does it indicate UTI? Would you start antibiotic for that? Anybody? Okay, मोहसिना ने हल्के हल्के कहा, जोर से नहीं कहा, जोर से बोलो. No, she will not. So cloudiness of urine most often is due to protein or crystal presence, and malodorous urine may be related to diet. So do not, it doesn't indicate that she has a UTI. Okay, imaging, anybody? What is the role of imaging? नीलोफर, लक्ष्मी, रुखसार, कराओगे इमेजिंग यूटीआई में? कौन से यूटीआई में कराओगे? History of recurrent or history of UTI, recurrent UTIs in childhood as well. And now she's again coming with all those things. So it is not going to help most of the time, okay? So no imaging studies are indicated. Renal function testing also. RFT is not indicated unless she's old and you want to prescribe her certain antibiotics which might, have an effect. So management is empiric antibiotic therapy, alternate. So about only half my slides are finished. Management पे आ गए, ज़्यादा सब लोग यूँ ही नहीं करने लगेंगे. ठीक है. So nitrofurantoin, trimethoprim, sulfamethoxazole, and fosfomycin. So why did I put fosfomycin as the third option, not the first? So all of them are first line drugs. You all are using a lot of fosfomycin. Doctor, can you share your this thing, the first line that you are using? You people? Nitrofurantoin. Yeah, we are also using nitrofurantoin, both in pregnant and non-pregnant. Yeah. So alternative are beta-lactams or fluoroquinolones. Okay. Selection of the agent depends upon the sensitivity, cost, anticipated incidence, and severity of adverse effects and dosing interval. Okay. So fosfomycin is so convenient for the patient. The most majority of the patients leave the treatment midway because they are relieved of symptoms, and symptoms are relieved almost the start of antibiotic therapy within 7-8 hours or maximum 48 hours. 7 to 10 day therapy was used historically, but now we all know that a shorter duration is enough. Shorter treatments offer the advantage of increased compliance, decreased cost, and reduced adverse effects. Okay. Now, other considerations, empiric antibiotic selection is determined in part by the local resistance patterns. Beta, because for example, in our part of the world, trimethoprim sulfamethoxazole combination has more than 20%, most of the studies, more than 20% resistance. So that is an indication for not using that. Okay, so beta-lactam antibiotics may be used when other recommended agents cannot be used because of any reason. Fosfomycin nitrofuran should be avoided in suspected early pyelonephritis because they will not work. Because if you know this is not even this is a bacteriostatic. It is not a bactericidal. So for pyelonephritis, it will not work, and maybe you are delaying the treatment. Okay, should be avoided in suspected early pyelonephritis. Limit the use of trimethoprim if the resistance is more than 20%, and fluoroquinolones are reserved for complicated cases. Nitrofurantoin, you all know, we are not going to discuss them in detail. So dose, you all know, 100 milligram BD for 5 days, for 5 days, for 5 days. No need for continuation for 10, 14 days, unless it's a case of a recurrent or there's some other reason that you want to. 79 to 92% initial cure rate is there. Then cotrimoxazole, 79 to 100% clinical cure rate. Okay. Fosfomycin, largely underused, single dose regimen, diarrhea, nausea, headache, 3 gram, we all know the dose, single oral dose. Clinical cure rate was initial studies, they found 91%, but now the later studies have reported a slightly lesser clinical cure rate. So nitrofurantoin is again, yeah. So fluoroquinolones, they have good tissue penetration, and you can use either ciprofloxacin or levofloxacin, and they have a higher risk of systemic effects and should not be considered first treatment. Okay. So I go back to mobile. So now a few, again another question, delaying therapy awaiting culture. What would you do? For example, a patient has come to you and you have sent a culture. So will it make a difference for uncomplicated lower urinary tract infection? It will not make. A simple cystitis, you can wait if you think that it is very important that you need a culture for that particular case, okay? Otherwise, cultures are not needed for most of the time, okay? Then anti-inflammatory agents, she's saying I am having dysuria, or symptomatic therapy that we are prescribing so many times, urine लाल हो जाएगा, उसको बता रहे होते हैं, pyridium. The local analgesic, मैम बहुत प्रिस्क्राइब करती थी डॉक्टर से क्या जब से हाँ बताइए भाई तो should we give it or not? So they can be given, but I told you that once you start the antibiotic, symptoms we just have to reassure her will subside within 5-7 hours or maximum 48 hours. Okay? So, but if you want, you can give pyridium, but tell her that it is going to cause redness of urine, discoloration of the urine, otherwise she'll be scared unnecessarily. हाँ कुछ बोला कोई? Any questions? तो question पूछने का भी chocolate है? हाँ. अभी आते हैं, आप ही बताइएगा. Okay, this question is for Dr. Dr. Aisha. Oh, I can't see. Sorry, Afshan, sorry. Yeah. Uh, do you prescribe while you're prescribing? Do you use this alkalinization or acidification of urine? Because earlier, when we were reading Harrison's, good old Harrison's, we used to remember those formulas. ABCL Corporation, I remember Amitabh Bachchan Corporation. Acidify in antibiotics. यार लाइट नहीं चल रही है अच्छा ये नहीं चल रहा वरना दिख जाता हाँ So I just deleted those two slides because I thought that nobody is using it for our part of the world. Yeah, yeah.
Or cystitis-like symptoms. So one thing is called methenamine hippurate, जो कि Hiprex के नाम से आता है. So it's 1 gram tablets twice a day for 3 months. Or D-mannose comes in a sachet or tablet. The dose is exactly same, 1 gram twice a day for 3 months. It is for those people who keep on having recurrent cystitis-like symptoms and would like to have some treatments, but giving antibiotics is more problematic. So we use those rather than
So they work, the mechanism of action is local.
So it is like an antiseptic, hippurate. Hiprex is like a local antiseptic, but it is very mild and it has no side effects. And D-mannose is a type of glucose which prevents bacteria from growing, but it's not an antibiotic. So these are the two commonest things which we use, along with, if a woman is over 50, we must use estrogen, vaginal estrogens with support. Yeah, it can be given because it's a different type of glucose. One more thing, when you were mentioning, sorry, I'll add the point, otherwise I will forget. When we were talking about different bacteria, so if culture has shown Proteus mirabilis, is there any association with anything? Do we have to be careful and think about something? If it is a very rare bacteria to pick up on a culture, but if a culture has shown Proteus, what should we think of? Any idea? There is a chocolate. Yeah? So if culture has ever shown Proteus mirabilis, we should think about a stone. It is associated with stone somewhere in urinary tract.
So the swarming property is especially related to solids, okay, the catheters and the stones, yeah. So this is what I was talking about, alkalinization and which antibiotics work better in which kind of, so we were, earlier we were using a lot of alkazol. But I did not have access to any book on nephrology, but Dr. Aslam told me that just by word of mouth, I never checked it. I was not able to check it, that now they are not following this, this principle. And sometimes, you need to, acidify the urine, and for that you use vitamin C, okay? And then, yes. Yes, related to use of pyridium, please do not use it for more than 2 or 3 days. it can cause many side effects. Okay, so recurrent 2 3 days at the most. Avoid, yeah. So now coming to these two terminologies, recurrent or relapsing UTI. So two or more infections in 6 months, or three in 1 year, but separated by at least 2 weeks, or at least documented success of first infection. And then relapse is recurrent infection with the same bacteria within 2 weeks of treatment of the original infection. Okay. So how do you prevent? Dr. Afsha just now told us some strategies. So one is continuous prophylaxis of antibiotics can decrease the risk of recurrent infection by 95%, but puts the patient at risk of side effects and colonization with resistant organisms. This is from Up to Date. There is no definite evidence indicating proper duration of treatment, but most advocate treatment for 6 months or longer. So these are the different antibiotics that you can use, but again there is a risk of those two risks you have to remember. Okay, then people use post-coital prophylaxis because many women, you must have noticed, they come and say, जब मेरी शौहर से बात होती है उसके बाद मेरे symptoms aggravate हो जाते हैं या reappear हो जाते हैं. So a single dose taken within 2 hours of intercourse should be considered in women whose symptoms seem temporarily related to intercourse. And when we're talking about the hygiene, we have to tell them that once you have had intercourse, it is better to go and avoid urine. Okay. Then self-treatment of symptomatic urinary tract infection is an alternative to prophylaxis. So most of the time, these women will be able to recognize that it is coming. And most of the time, they are correct in 80% of the cases. So they may start the prophylaxis at that time. So three strategies: continuous or post-coital when it has been related to intercourse, and then self-treatment whenever they think that the symptom is coming back. And then, of course, Dr. Afshan has been emphasizing on use of estrogen for the last 3 days. I have noticed that. So that is also improves, normalizes the vaginal flora, increases the prevalence of lactobacilli, and decreases the E. coli colonization. So what do we need? A follow-up. It is not required for uncomplicated single episodes. For patients who had hematuria on initial presentation, repeat analysis after a few weeks following therapy should be done. And if it is persistent hematuria, you need to evaluate them. Persistent or recurrent symptoms, again, need evaluation. And then if symptoms persist in a setting of appropriate antimicrobial therapy, urologic assessment and radiographic imaging to evaluate for anatomical abnormalities should be done. Now, this is something, one of my pet peeves. I'm not going into detail. I think I have already, how much time I have already taken? Exceeded? Half an hour ho gaya? Oh my God. Zakham teacher hote hain kuch. Okay, so I'll just skip this, only one, a few questions for you all. Okay, to clear certain, this is something I found very useful. Recurrent uncomplicated urinary tract infections and some interventions that they've discussed. Do we really need to treat asymptomatic bacteriuria? Do we need to treat them? Why? Why you don't want to support bacteria? Because it is the only culture some people have. So we do not need. In pregnancy, of course, please do not go back with this confusion. It is not, we are not talking about pregnancy. In pregnancy, you have to treat it, but for non-pregnant lady, we don't need to treat it. Okay? Then clinicians should not treat it, is from those guidelines that I just showed you. Okay? Then we have a few more questions. This is again I found from November 4, 2024, a few questions from this. Okay? Role of pharmacotherapy for prevention of UTIs. Okay. We already discussed that, isn't it? So let's see what these guidelines say. The clinical review found insufficient quality of evidence to enable a clear recommendation. Pharmacotherapy can be considered for the prevention of UTI in women with recurrent UTIs only. Okay. Role of cranberry juice or supplements in the prevention of UTIs. Anybody? Does it help? Doesn't? It helps. But do not use. Very good. Who gave the answer? Okay. One chocolate for her. So it helps, but please do not use in pregnancy. Okay. Sufficient quality and quantity of evidence found. No clear recommendation. However, it can be used for non-pregnant, but do not use for pregnant. Okay. Can water intake play a role in prevention of UTIs? Yes, no. So I don't have so many chocolates. So many people are correct. Clinical review found insufficient quality evidence to enable a clear recommendation. Cake. Why? Acha. ट्रॉपिकल ईस्ट्रोजन का रोल है. यस, ये तो राशिका को दे दो. प्रोबायोटिक्स. यस, नो. सुबोई को दे दो. शी इज फ्रॉम कम्युनिटी मेडिसिन, शी डिड हर डीजीओ फ्रॉम आवर डिपार्टमेंट. कोई ऐसा साइंटिफिक प्रोग्राम नहीं है इसमें सुबोई पूरे टाइम ना बैठती हो. और बैठती ऐसे हैं जैसे हम लोग पहले बचपन में मिला शरीफ में बैठते थे ना, बिल्कुल बहुत अकीदा था कि मतलब जैसे बहुत ही कोई स्पिरिचुअल एनलाइटमेंट होने वाला है. वो वाली बिल्कुल इनकी वो होती है सिंसियरिटी. ओके. What is the role of sensitivity and specificity of urinalysis for the diagnosis of UTIs, and when should clinicians order urine culture? I think this is just a repetition. We already discussed that. Okay. These are, I'll put those slides in the group so you will be able to see, compare the sensitivity and specificity of different methods. Okay. What are reasonable empirical treatments? We already discussed that. We will just switch that. What appropriate duration? Again, this is just a repetition, but I want to reinforce that nitrofurantoin 5 days, Cyplin DS 3 days, fluoroquinolones 3 days, oral phosphomycin single dose. Okay. Prevention strategies. Some of the postgraduates here. What prevention strategies for preventing lower genital tract infections? Huh? Hydration, yes. Plenty of fluids. Frequent bladder emptying. Say near to synthetic, because sometimes it causes so much excoriation of the skin, and then there is a colonization and there is ascending infection. Postcoital bladder emptying and hand washing. Hand washing when? Okay. Which toilet do you prefer? Should we prefer? We are copying, the West. And now, yeah, because of the knee problems also we are doing. So please, for public toilets, please follow the Indian rules. Squatting is much better if you can do it. The toilet handle can have up to 40,000 germs per square inch. Okay. So in the West, you have these things. Okay. So this is with reference to preventing UTI in residents. What would you like to add? Moments of hand hygiene apart from these. ये तो 5 सब करते हैं. सबको करना चाहिए. So before before going to the washroom and after using the washroom. Okay? Then I think okay, हाँ भाई. UTI is a common condition involving pain in the okay. What is important here? Short course antibiotics are highly effective. Prevention strategies can reduce recurrence. UTI in pregnancy, please remember, have potentially adverse effects both for the mother and the baby. Obtain a culture in all pregnant patients with suspected UTI, and also screen for asymptomatic bacteria and treat for asymptomatic bacteria. So just one last few slides, truth or dare. How many of you have catheterized a patient? Okay. So how many of you have washed your hands before wearing your sterile gloves? Truth and dare, बिल्कुल सच सच बात हो रही है, बेबी अजान हुई है, हाँ. तो वो जो स्लाइड मैंने दिखाई थी ना कॉटी की, वो याद रखना. प्लीज प्लीज प्लीज. So I'll not go into the details. Just try to remove, once you have inserted it in a sterile manner, remove it as early as possible. Because risk of infection increases 5% each day, 25% at 1 week, and 100% at 1 month. Zahra kahan chali gayi? Her mother was my guide. I remember she used to do cesarean sections without putting in a catheter because she was so much, she wanted to prevent urinary tract infections. Okay. Okay, so we have antibiotic resistance concerns and stewardship. You remember this famous saying from Osler, one of the first duties of a physician is to educate the masses not to take unnecessary antibiotics. And for us doctors, not to prescribe unnecessary antibiotics for unnecessary durations, okay? In unnecessary, combinations. पिपरसलिन के साथ मेट्रोनिडाजोल चलती चली जा रही है, क्यों चलती चली जा रही है, हमें नहीं पता. So, and of course, having an antibiogram and looking at it every month from your, this is from the microbiology department, I got it for you people. So thank you very much. I thought this is going to be how you're going to behave in my class, either on your mobiles. This is for the residents, of course. But I think the excitement and enthusiasm of the senior faculty rubbed on to you all. Thank you very much for your very kind interactive session. And I think Nishad deserves a chocolate for, every whole 3 days. She has been asking questions and answering questions. I've been observing on YouTube. Thank you.
One comment, only one comment which is clinically useful. Nowadays, we end up giving nitrofurantoin for all because this is the safer and all that. When we use prophylaxis with nitrofurantoin and it is more than 9 months, in any woman or anybody, we need to remember about lung fibrosis. So even with low dose nitrofurantoin, long-term use, long-term means 9 to 12 months or more, it can cause lung fibrosis. And if we don't know this, obviously, it will be missed. If somebody is on nitrofurantoin more than 1 year and comes with